Welcome to my series on clerking of a surgical patient. Today I will discuss what you should know in order to get a good history and perform a good examination on a patient with obstructive jaundice. In order to make things simple and easy, I shall do so in two parts. Obstructive jaundice is jaundice due to blockage of the biliary tree, especially the main bile ducts, the common hepatic and the common bile ducts. And the most common obstruction is due to stones, gallstone disease. This is a simple anatomy of the biliary ducts. We have the intrahepatic ducts, the right and left intrahepatic ducts is joined to form the common hepatic duct, which is again joined by the cystic duct from the gallbladder to form the common hepatic duct, which goes downwards and to the right to enter into the second part of the duodenum. Just before it is joined, it enters the duodenum, it is joined by the pancreatic duct to form the ampulla of water. Obstruction of whatever cause, stones or tumors, especially stones, anywhere along the bile ducts will cause proximal dilatation of the duct, leading to stasis of bile, which then becomes bacteria invasion and colonization to cause septic cholangitis, inflammation of the bile duct. What are the consequences of bile duct obstruction? First, there's dilatation proximally, leading to stasis of bile, followed by secondary bacterial infection. And because bile cannot reach the duodenum, because of this blockage, there will be malabsorption of fats and fat-soluble vitamins from the intestine. It can also cause jaundice. There's increase in conjugated bilirubin, which is congested. The liver becomes highly concentrated with conjugated bilirubin, which diffuses back into the blood to cause jaundice. And long-standing obstruction can lead to liver cirrhosis and liver failure. Bilirubin is formed. The metabolism of bilirubin takes place in three phases or three media. The first media here is the blood, where the dying red blood cells are destroyed, especially in the spleen, which is the main bulk of the function takes place in the spleen, where the unconjugated bilirubin is formed with the destruction of RBC. And this unconjugated bilirubin binds with albumin to be carried into the liver. And this is the second phase or the second media where the metabolism takes place. And within the liver, in a series of chemical reactions, the unconjugated bilirubin is conjugated to form with glucuronic acid to form conjugated bilirubin, which is water soluble, as compared to the unconjugated, which is non-water soluble. The conjugated bilirubin is excreted into the bile ducts, which carry this conjugated bilirubin into the third medium, that is the small intestine. In the lumen of the small intestine, bacterial proteases act on this conjugated bilirubin, converting to urobilinogen, which is then converted to stercobilinogen and excreted in the feces. The stercobilinogen gives the brownish color of the normal stools. While 90% of this urobilinogen is converted to stercobilinogen, 10 to 20% enters into the so-called enterohepatic circulation between the small intestine and the liver, which is actually recycling of the urobilinogen to be used again for digestion. A small amount of this urobilinogen is secreted back into the blood, which is then taken up by the kidney and is excreted in the urine. So in normal patients, it is possible to have trace amounts of urobilinogen in the urine. Now, what happens when there's a blockage of the bile ducts in obstructive jaundice? Okay, this red arrow here shows the site of blockage where the bile ducts are blocked. For example, this common bile duct. As a result of this blockage, conjugated bilirubin accumulates in the liver in high concentrations. And this high concentration of conjugated bilirubin diffuses back into the circulation, where most of it reaches every part of the body and it stains the tissues, especially in the conjunctiva, mucosa, oral mucosa, as well as the skin. Okay, and in the skin, it produces jaundice, the yellow discoloration, which we call jaundice. Some of this bilirubin, conjugated bilirubin, is taken up by the kidney as it is water soluble and is then excreted in the urine as in solution form of the conjugated bilirubin. And this is the bilirubin that gives the urine the dark color in obstructive jaundice. So the three changes in obstructive jaundice, dark urine and pale stools, can be easily accounted for by the blockage of the excretion or secretion of conjugated bilirubin into the lumen of the small intestine. In obstructive jaundice, is posthepatic. The blockage is posthepatic, where the bile ducts are blocked. So the conjugated bilirubin becomes elevated in the blood, and that causes the jaundice. It is increased in the conjugated bilirubin in the urine, and that gives you the dark urine, which is also known as hyperbilirubinuria. There's decrease or absence of bilirubin, which accounts for the pale colored or acholic stools. The other prehepatic and intrahepatic causes of jaundice are usually medical causes. Prehepatic is usually increased destruction of RBC, and this is known as hemolytic anemias, where the unconjugated urine, unconjugated bilirubin, and the urine bilinogen becomes markedly increased. In intrahepatic, both conjugated and unconjugated are elevated, and this intrahepatic jaundice is usually due to liver pathology, dysfunction. Okay. Next, we come to the history. What are the symptoms that you must look for in taking a good history from a patient of jaundice? First, the most common complaint is pain, and the pain is classically in the right upper abdomen. At times, it radiates to the right shoulder and to the back. The pain is usually colicky in nature and localized more to the right upper quadrant. It is usually accompanied with loss of appetite, nausea, and vomiting. Next is the yellow discoloration or jaundice, and these are usually visible initially in the eyes, then the mucous membranes, followed by the skin in severe cases. Patient also complain of dark urine, okay, which is very important to ask the patient about his dark urine. Okay, how long it has been occurring? Is it been progressive? Is it due to dehydration? You must make sure that it's not due to dehydration. Okay, it is really hemoglobinuria. Then the stools pale, and these are not easy to know the stools are pale. Okay, and they are classically described as clay-colored stools. In hemolytic jaundice, patient can have pallor due to severe loss of hemoglobin. Itchiness is another classical sign of obstructive jaundice, symptom of obstructive jaundice which must be inquired. Fever, in case with obstructive jaundice or blockage of the CVD, is usually accompanied with chills and rigors. Fever tends to be high with chills and rigors due to secondary bacterial infection of the bile ducts. It is very important to inquire into the weight loss in the patient, because the other common cause of obstructive jaundice apart from stone is tumor. Okay, a malignant lesion in the causing obstruction of the bile ducts, and these lesions usually produce marked loss of weight in the patient. Next, we come to the physical examination. What are the signs that you will look for? Okay, as I mentioned, jaundice is a very common sign which is noticed in most patients, associated with scratch marks. And I said the patient has got severe loss of weight, is usually emaciated, and at times cachectic, easy bruising due to lack of vitamin K, which is not absorbed due to the absence of bile in the small intestine, and hepatomegaly, which is due to congestion of the liver with conjugated bilirubin, which is not able to secrete into the bile ducts. We can get splenomegaly. Gallbladder can be enlarged, and this is in keeping with Courvoisier's law. If it is enlarged in a patient with obstructive jaundice, it is most likely not caused by obstruction by gallstones, but more likely to be a sinister malignant lesion in the head of the pancreas, cholangiocarcinoma, or periampullary carcinoma. Patient can have abdominal masses. It's very important to carefully examine the patient. Liver masses, gallbladder masses, and masses around the lower epigastric or right paramedial area for pancreatic head lesions. Evidence of secondaries must be looked for, especially ascites, and this can be ascertained by fluid through if the ascites is massive, or shifting dullness for minor cases. This can also be associated with ankle edema, which is also a sign of advanced liver disease. And rectal examination is an important part of examining a jaundice patient, especially at times you may be able to get clay-colored stools on the examining finger, which can clinch a diagnosis of obstructive jaundice. And in order to understand, or in order to take a good history and do a physical examination, proper physical examination, you must, at the back of your mind, keep the causes of obstructive jaundice in that particular patient in the back of your mind, and asking the questions which are relevant or direct questionings related to these causes in order to come to a definitive diagnosis. First, the most common cause is choledocholitis, a stone in the CVD which causes blockage, stasis, and infection of the bile ducts. Bile duct strictures are another common cause, and the most common cause of these strictures is a previous passage of a stone, especially causing damage to the mucosa of the lower end of the CVD, which then heals with a stricture. Acute pancreatitis is another common cause of obstruction of the lower end of the CVD, resulting in acute CBD obstruction, and jaundice. Malignancy, especially of the head of the pancreas, cholangiocarcinoma and ampullary carcinoma must be all considered in chronic jaundice, painless jaundice, and in patients who are advanced in age. The other causes are occasionally seen: sclerosing cholangitis, congenital biliary atresia, Caroli's disease, choledochosis, and of course, not to forget, the other medical causes such as hepatitis and hemolytic jaundice. We must not forget the 4 important eponyms that are related to obstructive jaundice and diseases of the biliary tract. These are the Covaceous law, Murphy sign, Charcot-Stripe, and Raynaud-Spenta. Okay, you must know what these eponyms mean and what they suggest as far as the diagnosis is concerned. Covaceous law: in a patient with obstructive jaundice, if the gallbladder is palpable, then the cause of the jaundice is unlikely to be due to gallstone disease. On the other hand, it must be more likely to more sinister causes such as carcinoma head of the pancreas, cholangiocarcinoma, and periampullary carcinoma. Murphy sign is the halting of respiration in deep inspiration when pressure is applied over the right hypochondrium. This is due to the inflamed gallbladder that's hitting on the examining hand, causing pain which stops the patient from breathing. Charcot-Stripe, it consists of 3 things: right upper quadrant pain, jaundice, and fever. And these 3 symptoms tend to be intermittent in cases of gallstone obstruction. And the last one is Raynaud-Spenta, which in addition to the Charcot-Stripe, there is hypotension and mental disorientation. And just these 2 parameters are due to impending septicemic shock in a patient with obstructive jaundice. Obstructive jaundice, in summary, is caused by obstruction of the bile ducts. Relatively common and may lead to great consequences if left untreated. Symptoms and signs are quite straightforward and easily elicited if only you understand its pathophysiology. Must always remember the common causes of obstructive jaundice. When you quiz and examine the patients with obstructive jaundice in order to come to a logical diagnosis. For more information, you can go to my link on obstructive jaundice. You can go to my link which is stated here. Thank you.